Let's start. Is my screen visible to everyone?
Yeah. السلام عليكم دكتور خالد.
السلام عليكم. عامل ايه يا دكتور خالد؟ اخبار حضرتك؟
الحمد لله. How are you, doctor?
Fine, thank you, Dr.
Thank you.
This is interactive session, so I hope everyone can be interact with us. Everyone can stop me and do a comment or ask a question about everything. This topic, hypoglycemia, is very important in SCE and European board examination because at least 3 to 4 questions from this topic. And we will discuss hypoglycemia from Oxford Handbook, the 3rd edition. If anyone wants to review the book, this is the page 6 to 8. And also I comment or some topics from Greenspan book and some from Williams Endocrinology textbook. And also I will prepare presentation about very important guidelines published by Joint of British Diabetes Society, published 2018 about the hospital management of hypoglycemia in adults with diabetes mellitus, the 3rd edition. And this guideline is very important because at least 2 to 3 questions from this guideline. Another guidelines, I will do a hint about it, which is published by Endocrine Society, Evaluation and Management of Adults with Hypoglycemic Disorders. And a lot of data will be repeated to memorize it from every source. And I also will do a comment about this paper. This is a fantastic paper published in the European Journal of Endocrinology about pathogenesis and management of hypoglycemia. Let's start. Inshallah, in the next presentation, in every presentation prepared by me, I will do like this. In the first, I will notify about the reference from books and guidelines and papers if it is available. In the start, the approach of hypoglycemia must be fulfilled the Weibel's triad, which means plasma glucose less than 2.2 millimole per liter, plus symptoms of neuroglycopenia or symptoms of hypoglycemia, and these symptoms must be reversed with correction of glucose level by intake or intravenous or intramuscular injection. This is the Weibel triad. So if a patient presented to me with blood glucose less than 2.2 and there is no symptoms in neuroglycopenia, and this this manifestation is not corrected by glucose, this is not a hypoglycemia. And of course, the first defense mechanism against hypoglycemia is insulin suspension. This occurred by pancreas once hypoglycemia occurred. The first manifestation which occur in the body is insulin to decrease and suspended or stopped. This is normally. And another mechanism, glucagon will be elevated and cortisol and epinephrine and so on to reverse the hypoglycemia. Of course, after suspension of insulin, the first manifestation of hypoglycemia is by stimulation of glucagon from the pancreas, and this is occur if blood sugar less than 3.7. This is a counter-regulatory hormone. This is the first one. After that, if the blood glucose is less than 3.3, autonomic symptoms will be presented or adrenergic symptoms. And if blood glucose is go down to 2.8, this is the neuroglycopenic symptoms or cognitive dysfunction. This is the cutoff points which presented by manifestation of hypoglycemia is very important because some of the questions ask about this. And this order, the first counter-regulatory hormone, after that is autonomic symptoms, after that is a neuroglycopenic symptoms. This order is presented in our previous examination of SCE and European board. So it is very important to memorize this. Of course, as we know, symptoms and signs of hypoglycemia is all of us know it. Adrenergic symptoms like sweating, hunger, tingling, trembling, palpitation, and anxiety. And this will be occur if blood sugar is less than 3.3 millimole per liter. And the neuroglycopenic symptoms occur if blood sugar is less than 2.8, like visual disturbance, poor concentration, drowsiness, lethargy, and personality change, confusion, seizures, and lastly, coma. The mechanism of hypoglycemia, one of very important mechanism of hypoglycemia is insulin, either endogenous insulin or exogenous insulin or insulin abuse or another drug like insulin, like sulfonylurea, for example. And also, if IGF-1 or 2 is increased, it may cause hypoglycemia, and also impair the neuroendocrine response with inadequate counter-regulatory hormone. For example, if adrenal insufficiency, the patient may be presented by hypoglycemia because there is no cortisol sufficient to counteract the hypoglycemia. And also, impairment of hepatic glucose production, like end-stage liver disease, may be manifested by hypoglycemia. Classification of hypoglycemia is not very important, but at least clinically important, because there are two types, and every type has a specific investigation. Fasting hypoglycemia, this occurs several hours, typically after 5 hours after the food intake. And postprandial or reactive hypoglycemia occurs within 2 to 5 hours after food intake. And of course, insulinoma may be fasting or postprandial, and so on. This is classification from Oxford handbook. This classify the cause of hypoglycemia in adults into two categories, two main categories. Medicated individual, or the patient is ill, and another category if the patient seemingly well individual. This is another cause of hypoglycemia. Let's start by a medicated individual or severely ill, drug induced. For example, the patient received insulin or secretagogue can cause hypoglycemia, or alcohol, and mechanism of alcohol to induce hypoglycemia by impairs of hepatic gluconeogenesis. And we must remember that if the patient hypoglycemia caused by alcohol, intramuscular glucagon is not effective in treating hypoglycemia. This is very important. So glucagon is not correct choice for management of hypoglycemia in a patient receiving alcohol, or the patient of chronic liver disease, or the patient who receives starvated. And other drugs that can cause hypoglycemia, like pentamidine, quinine, glucagon also can cause hypoglycemia. And organ failure, this is another category like liver cell failure, chronic renal failure, sepsis like malaria or gram-negative or meningococcal. Hormonal deficiency, cortisol deficiency like Addison or hypopituitarism can be presented by hypoglycemia. And this is very important, which is non-islet cell tumor. In our previous exam, 2019, there is a question about IGF, and I will put the question. Non-islet cell tumor, this is by excessive IGF-2. We must remember that the IGF is similar to insulin molecule in structure, and can attach to the insulin receptor and cause hypoglycemia like insulin. So it may be the patient presented by hypoglycemia. And of course, IGF-2 secretion from large mesenchymal tumor like non-islet cell tumor hypoglycemia. This is a non-islet cell tumor hypoglycemia like fibrosarcoma or mesothelioma, and so on. This is the patient is medicated, apparently ill. If the patient is apparently well, this is another category of hypoglycemia like insulinoma, which is benign in about 85%, 85% or 90%, malignant just 10 to 15%, and of course it is maybe a part of mean one. Non-islet cell tumor, we see here a non-islet cell tumor can be presented in a medicated individual or ill individual, and also may be presented in seemingly well individual. And in this case, adrenal carcinoma, pheocarcinoma, hepatocellular carcinoma, lymphoma, myeloma, leukemia, or advanced metastatic malignancy, all of them can secrete IGF-2 or 1 or another mediators that can cause hypoglycemia. And another very important one is functional beta cell disorder, nesidioblastosis, and this is similar to insulinoma, but it is not insulinoma. Serum insulin will be elevated in this category of the patient functional beta cell disorder. And this is typically hypoglycemia after eating, and this is very important, which is post-gastric bypass hypoglycemia, and which can be treated by alpha, of course, by diet modification, and another modality for treating post-gastric bypass hypoglycemia by alpha glucosidase inhibitor, diazoxide, or ectreotide. This is very important because in our exam there is another question about post-gastric bypass hypoglycemia or nesidioblastosis. Another very important and very rare type of hypoglycemia, cause of hypoglycemia, which is autoimmune. Autoimmune, mechanism of action antibody to insulin. It is very rare, just 200 cases reported all over the world, most of them from Japanese or Korean descent. So it is very, very, very rare, but may be encountered in the exam. And we must notice that in autoimmune hypoglycemia caused by autoimmune antibody to insulin, elevated free insulin, serum insulin is elevated, not suppressed, and typically associated with late postprandial hypoglycemia. And the last one is accidental or factitious hypoglycemia caused by insulin or insulin secretagogue like sulfonylurea and so on. The data presented in this table will be repeated a lot of times to memorize. This is another table to classify the cause of hypoglycemia in outpatient setting or inpatient setting. This is not very important, but how to investigate a case of hypoglycemia, we must all remember that bedside test or glucosometer is not accurate or unreliable for detection of low glucose concentrations. We must investigate hypoglycemia by blood samples. Yes, Dr. Muhammad? Yes, Dr. Muhammad, listening to you. Dr. Muhammad Himeda, you raised your hand. Welcome, Dr.
اوكي دكتور لا تو اوكي كلير شكرا بارك الله فيك.
اوكي دكتور سفيان مرحبا.
ما تعمليش حاجه يا ماما.
عليكم السلام ورحمه الله. ازيك يا دكتور خالد؟
عامل ايه اخبارك؟ عامل ايه اخبار حضرتك؟
الحمد لله تمام.
عايزين نسمع صوتك او نسمع صوت المجموعه كلها.
الله يسلمك، الله يبارك فيك.
ربنا يبارك.
سفيان كل سنه وانت طيب ان شاء الله.
كل سنه وانت طيب يا حميد، ان شاء الله يديك بالصحه والسلامه.
الصوت بتاعي واضح ولا في مشكله يا دكتور سفيان او دكتور محمد؟
ما تعمليش حاجه خلاص.
الدكتور محمود عزت ده ولا مين؟
مش عارف والله.
انا مش عارف، بس سامع صوت حد، بس انا مش شايف صوت الدكتور محمود. الدكتوره سمر، الدكتور خالد، ماشي. This is investigation for a case of hypoglycemia. Of course, liver and renal function test must be ordered, and the glucose strip in the first, and of course the blood plasma sample, and synactin test to exclude adrenal insufficiency. And the most important is insulin, C-peptide, the proinsulin, and the glucose during hypoglycemia. This is the most important test to be ordered in a case of hypoglycemia: insulin, C-peptide, proinsulin, and the glucose during hypoglycemia. And this is a very important notice about inappropriately elevated insulin in the presence of hypoglycemia suggests one of the following differential diagnosis. Serum insulin is elevated in the presence of hypoglycemia. The most important one, and all us know it, is insulinoma, but also self-administration of insulin sulfonylurea can be presented by elevated insulin. Post-gastric bypass hypoglycemia or nesidioblastosis is presented by elevated insulin. Non-insulinoma bacteriogenous hypoglycemia, which is non-islet cell tumor, presented by elevated insulin. And also insulin autoimmune is presented by elevated insulin. This is the differential diagnosis for elevated insulin and of course with hypoglycemia. Insulinoma, insulin sulfonylurea abuse, post-gastric bypass, non-insulinoma pancreatitis hypoglycemia, and insulin autoimmune hypoglycemia. In our previous exam, I think presented by one of them, I will present the question. Absence of C-peptide but the presence of insulin during hypoglycemia suggests one of two: exogenous insulin administration or raised IGF-2. I think in our exam there is suppressed C-peptide and low insulin and of course hypoglycemia. And I think the correct answer is CT abdomen or MR abdomen. Insulinoma often associated with elevated pro-insulin to insulin ratio. This is the insulinoma. Fasting beta hydroxybutyrate is elevated in most causes of hypoglycemia, but suppressed if insulin present. So in most of cases of hyperinsulinemia, the fasting beta hydroxybutyrate will be low. Consider IGF-1 and IGF-2, and the ratio of IGF-1 to 2 may be helpful in some cases of non-islet cell hypoglycemia. And of course, chest and abdominal radiography like CT may be needed to diagnose this category of hypoglycemia. And of course, the last, if we suspect insulin autoimmune hypoglycemia, we can consider insulin and insulin receptor antibody, which is not common lab in our laboratories in Egypt. The further investigation for fasting hypoglycemia, the most important one is 72-hour fast. This is the gold standard to diagnose insulinoma or to deal with a case of hypoglycemia. And of course, this test is the most reliable test for hypoglycemia. This is the gold standard for diagnosis of insulinoma. The patient should remain hydrated and active, because with exercise and activity, it leads to hypoglycemia, which can provoke a hypoglycemic manifestation. And of course, we must measure the plasma glucose and insulin and C-peptide and the proinsulin during the attack of hypoglycemia during this test. And beta hydroxybutyrate should be measured at the end of the fast. And of course, we must terminate the test if the blood glucose is less than 2.2 or after 72 hours. And of course, this test has a specific protocol. If weight loss more than 5%, we must suspend the test, and so on. And must be, of course, supervised by someone. And of course, during this test, we must notice that non-caloric diet or another method of fluid like water and non-caloric fluid is safe to be administered during this test. And also, C-peptide suppression test is not a very important test. This is very important to differentiate between the three most common causes of hypoglycemia: insulinoma, sulfonylurea abuse, or insulin injection. All of them, blood glucose is less than 2.2. This is the threshold for Weber triad. Insulin is elevated in the insulinoma and sulfonylurea, but in insulin injection, insulin abuse, both of them insulin is elevated, serum insulin is elevated. In insulinoma, C-peptide is elevated. In sulfonylurea, C-peptide is elevated, but in insulin abuse, C-peptide is low. This is very important. How to differentiate between insulinoma and sulfonylurea? Just by serum or urine sulfonylurea screening. So if in any case, if serum insulin is elevated, of course, blood glucose is low. Serum insulin and C-peptide is elevated, so we must differentiate. Is it insulinoma or sulfonylurea abuse? So the next step is to do serum or urine sulfonylurea screening. Of course, in insulin abuse, C-peptide is low, suppressed. This is the clue to differentiate between these three very important categories. Another investigation for postprandial hypoglycemia, which occur after 5 hours after eating, postprandial within 2 to 5 hours. A mixed meal test over 5 hours. This is more physiological test, use food, some specific foods, and to do the test. This is the postprandial reactive hypoglycemia. This is imbalance between glucose influx into which is from exogenous, from the food, or endogenous glucose production from the liver, and the glucose efflux to this out of the circulation by some of the GLUT receptors. The pathogenesis of postprandial or reactive hypoglycemia, exaggerated insulin response, for example, after post-bariatric surgery, or incipient diabetes mellitus or rate hypoglycemia of occurred diabetes. This is the first presentation of type 2 or type 1, which is impaired glucose tolerance, or early type 1 or type 2 may be present by reactive hypoglycemia. And this is occurred mechanism delayed insulin secretion pattern, which produce late hypoglycemia 4 to 5 hours after ingestion of glucose. So hypoglycemia can be a clue for diagnosis of diabetes mellitus. And also a pathophysiology of 8 insulin resistance related hyperinsulinemia, impaired glucagon sensitivity and secretion, or renal glucosuria, or body composition. This is the massive weight reduction increase the risk of reactive hypoglycemia. And of course, some of diets can cause reactive hypoglycemia. For example, high carbohydrate and low fat diet increase the insulin sensitivity and can cause hypoglycemia. And alcohol, of course, inhibit hepatic glucose output, and in some case, reactive hypoglycemia may be idiopathic. And of course, how to investigate a case of reactive hypoglycemia by prolonged oral glucose tolerance test. It is not physiological. 10% of normal asymptomatic population have a positive response. The most important is hyperglycemic mixed meal test or mixed meal test. And this is from, I think, Greenspan, these 2 tables for this test. This is not very important actually. But we must know that the management of we must know that the management of reactive hypoglycemia by diet. This is the most important step for management by frequent, small, low carbohydrate, high protein meals. Avoid rapidly absorbed carbohydrate, avoid sugary drinks, especially in combination with alcohol, and addition of soluble dietary fiber. If this fail to improve the symptoms, another drugs can be used. The first one is acarbose, which alpha glucosidase inhibitor. This is the best one. Another one, metformin, can be useful, 500 milligram with meals, and another one, diazoxide, and the last one is somatostatin. So acarbose, metformin, diazoxide, somatostatin. And of course, propranolol and calcium antagonists have been used. However, controlled studies are lacking. So we have 3 options after a diet: acarbose, diazoxide, somatostatin. The best one is acarbose. If not available, so diazoxide or somatostatin, we can suggest which one is the best according to the situation or case scenario. Of course, the most common cause of hypoglycemia in the case of diabetes is the use of anti-diabetic medication. Of course, if a case of diabetes type 2 or type 1 diabetes present by hypoglycemia, we must suspect renal and hypopituitarism or hypoadrenalism. This is not common. The most common is abuse of a drug or overdosage of a drug, insulin or sulfonylurea or another drug that can potentiate the effect of this drug. And we must know that the risk factor of hypoglycemia in the case of diabetes in age of more than 70 years and older, renal failure, hepatic failure, and use of long-acting sulfonylurea. And also drug-drug interaction is very important, like clarithromycin, salicylate, sulfonamide. This drug can interact with sulfonylurea and cause hypoglycemia. And in that situation, the management by modification of the drug, and of course, in some cases, if the patient receive long-acting sulfonylurea, we can use intravenous dextrose, and if not available or not correct the case, we can use diazoxide or octreotide in some very rare cases. Factitious hypoglycemia, it means the patient receives sulfonylurea or insulin to induce hypoglycemia by himself. In this scenario, there are hypoglycemia, serum insulin level is elevated, and suppressed plasma C-peptide if the offending drug is insulin. But if sulfonylurea, insulin is elevated and the C-peptide is elevated. The pathogenesis of exogenous insulin administration in non-diabetic patient is suppressed pro-insulin level. C-peptide is suppressed, serum insulin is elevated, suppressed pro-insulin level. This is the pathogenesis of exogenous insulin abuse. Of course, the insulin is mainly the insulin is excreted from the liver or from the kidney. Clearance of insulin. Kidney. Endogenous insulin excreted by the liver, but exogenous insulin is excreted by the kidney. So it is very important to know that the insulin is secreted into the portal circulation in a molar ratio 1:1 with the C-peptide. The liver is the primary site of insulin clearance. This is the endogenous insulin, but exogenous insulin cleared by the kidney. And so if in our patient, if the patient is received insulin, the insulin is cleared by the liver. The C-peptide, on the other hand, is mostly cleared by the kidney at a slower rate than insulin. So in our case, insulin to C-peptide is less than 1 in the case of factitious hyperinsulinemia. Of course, if the patient is renal failure, this ratio is reversed and more than 1. And of course, if we suspect sulfonylurea, we must do plasma or urine screening for sulfonylurea. This is very important drugs because in our exam previous there is a question about it. Drugs, there are some drugs which potentiate the effect of insulin and predispose to hypoglycemia, like fluoroquinolone, pentamidine, quinine, ACE inhibitor, ethanol, salicylate. This is very important, salicylate and beta blocker. And this table from the Endocrine Society guidelines for hypoglycemia, gatifluoxacin, which is quinolone, endomethacin, glucagon, lithium, and ACE and beta blocker, and mifepristone, which is mineralocorticoid receptor antagonist, and heparin. And this table is important because it is from the guidelines. This is a list of a drug which can potentiate hypoglycemia. Concurrent use of this medication can cause hypoglycemia in a case of type 2 or type 1. Warfarin, quinine, salicylate, very important salicylate, fibrate, sulfonamide, MAO, non-steroidal anti-inflammatory drugs, propensid, somatostatin analog, and SSRO. Salicylate, warfarin, quinine, fibrate, sulfonamide. This is very important drugs because in our exam there is a question about this. And in previous exams, in every exam, I think there is a question about it. I will repeat the autoimmune hypoglycemia. This is the very, very rare, just 200 cases reported, most of them from Japan. Hypoglycemia generally occurs 3 to 4 hours after a meal and follow an early postprandial hyperglycemia. The most pathognomonic for autoimmune hypoglycemia is high titer of insulin autoantibody, which is IgG, and insulin C-peptide level may be elevated. In most cases, serum insulin is elevated. And results may be erroneous because of interference of insulin antibody with the immunoassay for this peptide, but in exam, they will mention that the serum insulin is high. The management of this syndrome achieved by dietary treatment with frequent low carbohydrate small meals and prednisolone corticosteroid in a case of diabetes may be used in high dosage, has been used to lower the titer of insulin and tapering its dose after 2 weeks. And this is, notice I highlight it is very important. Almost all of these patients have also had episode of insulin resistance to diabetes, and against those negligence, most of reported cases of autoimmune hypoglycemia. This the patient is present by hyperglycemia, severe hyperglycemia followed by severe hypoglycemia. واللي متابع الدكتور البوستات بتاعت الدكتور عمرو عمر كان حاطط حاله بخصوص الاوتوميون هايبوغلايسيميا في الحالات بتاعته. الهايبوغلايسيميا was found to respond to glucocorticoid therapy but not to plasmapheresis or immunosuppression. This is from Greenspan, but in another sources they mentioned that plasmapheresis and immunosuppression can be used to treat resistant case of autoimmune hypoglycemia. We will discuss insulinoma because it is بطريقه او باخرى related للهايبوغلايسيميا. Definition of hypoglycemia: insulinoma is a functioning neuroendocrine tumor of the pancreas that cause hypoglycemia through inadequate secretion of insulin. Most of them are benign, more than 90%, in another scenario 85%. More than 80% of insulinoma are solitary, and of course 10% of insulinoma associated with MIN1. This percentage is important because in the real exam they asked about some of percentage. But we must know that insulinoma are found with equal frequencies through the head, body, and tail of pancreas. And of course, the prevalence of insulinoma is just 1 to 2 cases, and in some references 4 per million population. There is a slightly female preponderance in the 5th decade of the life. 10% is associated with MIN1. Of course, to diagnose a case of insulinoma, we must apply Weber triad in the first. Blood sugar is less than 2.2, symptoms hypoglycemia, and reversible of these symptoms after glucose intake. The gold standard to diagnose insulinoma is by 72-hour fast. And this test, patient can drink water and decaffeinated non-alcoholic drinks. It is important that patients are active walking during the fast, since exercise may help precipitating of hypoglycemia. Of course, the patient, most of patients just 15 hours or 24 hours and the precipitated hypoglycemia, and the test stop. A diagnostic criteria for diagnosis of insulinoma: blood glucose is less than 2.2. Concomitant inadequate insulin elevation is elevated. Of course, insulin is elevated, and of course, C-peptide and proinsulin is elevated, and of course, beta hydroxybutyrate is low, less than 2.7, because this is endogenous hyperinsulinemia, and so beta hydroxybutyrate is low, and of course, absence of sulfonylurea and metabolite in plasma or urine. And this table from Greenspan put the diagnostic criteria for diagnosis of insulinoma with 72-hour fast. This is not very important. At least we must know that glucose is low, plasma insulin is elevated, plasma C-peptide and the proinsulin is elevated, beta hydroxybutyrate is low, and sulfonylurea screening is negative. In normal means, the blood glucose value does not fall below 3.1 during the fast, 72-hour fast, whereas insulin level fall below 10. So serum insulin is suspended or suppressed, and the blood glucose, when blood glucose is less than 3. This is very important hint. In some normal women, however, plasma glucose may fall below 30 milligram per deciliter. 30 milligram. This is not a case of hypoglycemia because there is no symptoms of hypoglycemia. But serum insulin level also fall upward to less than 5. So it is serum insulin is low, and the blood glucose is 30%. This is asymptomatic, so it is not a case of hypoglycemia. This is a reported case in females. In a case of insulinoma, we must localize the tumor, and we must know that islet cell tumor are often small, and in about 40% the tumor cannot be localized. MRI or spiral CT correctly detects about 60% of the tumor. Arterial stimulation with calcium secretion may be used in some cases to localize the insulinoma, but the most important one is endoscopic ultrasonography, which is the most sensitive method for localization of insulinoma. Endoscopic ultrasonography. Of course, intraoperative ultrasonography is more sensitive, but it is intraoperative. Before operation, endoscopic ultrasonography is the best modality for localization of insulinoma. Somatostatin receptor scintigraphy for glucagon-like peptide 1 receptor imaging may be useful in some cases. And this is انا ما اعرفش الدكتور ابراهيم with us ولا لا الدكتور ابراهيم. Okay. I think this image from Greenspan, this show insulinoma here, CT abdomen. This is insulinoma in the pancreas. Of course, treatment of insulinoma mainly surgical treatment, but in some cases which inoperable, we can use a medical treatment to control symptoms like diazoxide alone or in combination with octreotide or somatostatin analog until surgery, or some patients can receive diazoxide for a long period if he is inoperable. So the treatment of insulinoma mainly surgical, medical therapy to just control symptoms in some cases. And of course, the prognosis of insulinoma following the removal of oscillatory insulinoma, life expectancy is restored to normal. And of course, the malignant insulinoma, metastasis mainly to the liver. And of course, mortality is high if malignant insulinoma. The average 5-year survival estimate to be approximately 35 for a malignant insulinoma. A non-islet cell tumor, this is very important. Non-islet cell tumor, this is presented by fasting hypoglycemia, large and mesenchymal in the origin, retroperitoneal fibrosarcoma. Mainly, serum insulin is low, below 5. يبقى so in non-islet cell tumor hypoglycemia, this is non-islet cell tumor hypoglycemia. This is not. There is another modality which is non-insulinoma pancreatogenous hypoglycemia, which is presented by elevated serum insulin in the most cases, but non-islet cell tumor hypoglycemia presented by fasting hypoglycemia. Serum insulin is low, less than 5, and insulin-like growth factor 2 may be elevated, but IGF-1 is low. And the ratio of IGF-2 to IGF-1 is elevated because IGF-2 is the elevated one. So serum insulin level below 5, plasma glucose is low, growth hormone IGF-1 are also decreased, but IGF-2 may be increased, but often are normal. This table is very important table, and this table I will repeat it a lot of times. This is from I think Williams' textbook of endocrinology, the latest edition. A normal person, blood glucose if less than 2.2, this is not 2.2, 2.2 is about 45 أو هذا الرقم يعني. This is 55 milligram per deciliter. No symptoms of hypoglycemia, blood glucose is low, but no symptoms of hypoglycemia, this is a normal. This is not a hypoglycemic case. Not to order another test. Once there is no manifestation of hypoglycemia, this is a normal. In exogenous insulin abuse, of course, serum hypoglycemia and symptoms of hypoglycemia. Serum insulin is elevated, but because serum insulin, this elevated serum insulin from exogenous, so C-peptide will be low. And of course, the proinsulin, because the insulin is just cleavage proinsulin. Proinsulin, this is a step which cleave to insulin and C-peptide. So if insulin is C-peptide is low, so proinsulin is low in exogenous insulin. And of course, the beta hydroxybutyrate is low because serum insulin is elevated. And of course, the glucose after glucagon is elevated, and hypoglycemia is not. This is exogenous insulin. So in exogenous insulin, the 3 parameters is very important. The glucose is low, serum insulin is elevated, C-peptide is low, proinsulin is low. Another one, insulinoma, non-islet cell or non-insulinoma pancreatogenous hypoglycemia or post-bariatric surgery hypoglycemia, all of them, symptoms of hypoglycemia, blood glucose is low, but serum insulin is elevated. يبقى in insulinoma, non-insulinoma pancreatogenous hypoglycemia and post-gastric bypass hypoglycemia, all of them serum insulin is elevated, C-peptide is elevated, proinsulin is elevated, and beta hydroxybutyrate is low, and of course no oral hypoglycemic drug in the urine or stool. or serum, and of course negative insulin autoantibody. If the patient receive oral hypoglycemic agent sulfonylurea, the same, the serum insulin is elevated, the C-peptide is elevated, the pro-insulin is elevated, the same as insulinoma, but here the sulfonylurea screening is positive. This is the differential diagnosis between sulfonylurea abuse and insulinoma or non-insulinoma, pancreatitis hypoglycemia, or post-gastric bypass or nesidioblastosis. Insulin autoantibody, this is very important because serum is the same, serum insulin is elevated, C-peptide is elevated, the pro-insulin is elevated, the beta hydroxybutyrate is low, but here no sulfonylurea, but the insulin autoantibody is positive. The insulin autoantibody is positive. This is the differential diagnosis between insulin autoimmune and oral hypoglycemia and insulinoma and another category. The IGF-1, here serum insulin is low, and of course C-peptide and the pro-insulin is low, and beta hydroxybutyrate is low, and of course no insulin autoantibodies. This is the differential diagnosis between IGF-1 and insulinoma. In insulinoma, serum insulin is elevated. In IGF, serum insulin is low. In another category, which is not insulin or IGF mediated, the same. Serum insulin is low, C-peptide is low, pro-insulin is low, beta hydroxybutyrate is elevated. This is the differential, how to differentiate between IGF mediated, not insulin or IGF mediated, and IGF-1. The main is between beta hydroxybutyrate. In the IGF or another categories, beta hydroxybutyrate is low, and not insulin or IGF mediated, beta hydroxybutyrate is elevated. This is just a reminder from this article, very important article published in the European Journal of Endocrinology, Pathogenesis and Management of Hypoglycemia. This is just to remember some of points. The first defense against hypoglycemia is cessation of insulin secretion from the beta cell. The next one is the glucagon secretion from pancreas. Epinephrine is also an important factor in preventing hypoglycemia, and we must know that epinephrine and the growth hormone is not very important in as a counter-regulatory hormone, except in a case if glucagon secretion is abnormal or epinephrine is abnormal, so growth hormone is the next one. Is the same as we mentioned previously. This is the same data. Here he mentioned that the insulinoma, the prevalence of insulinoma 4 per million patient per year, and of course, as we mentioned previously, compute CT or MRI, transabdominal ultrasonography, and the tumor inoculation is the mainstay of management. Dazoxide and the somatostatin or ethanol ablation may be used as alternative to the surgery. Post-bariatric hypoglycemia, which is nesidioblastosis, this is more common in the women than in the men, and mainly presented by postprandial symptom. And the first line therapy in this is dietary modification. After dietary modification, an alpha glucosidase inhibitor or somatostatin or diazoxide may be used, and in some cases, the pancreatectomy can be used as a treatment in these cases. In non-insulinoma pancreatitis hypoglycemia, this is confused with post bypass hypoglycemia nesidioblastosis, but there is no history of surgery, of bariatric surgery. In this case, endogenous hyperinsulinemic hypoglycemia, and of course, hypoglycemia typically occur postprandial. And of course, the diazoxide and the diagnosis usually require a selective arterial calcium stimulation with hepatic venous sampling. Diazoxide and distal pancreatectomy can be used for treatment of this case. Autoimmune, as we mentioned previously, it is a very rare case, but in this scenario, serum insulin is mainly higher than 1,000 picomole per liter. And of course, insulin autoantibody, if ordered. Here, he mentions that in case of refractory steroid, other therapies such as azathioprine, plasmapheresis, and rituximab have been used. This is from Greenspan, but in Oxford Handbook, they mentioned that plasmapheresis and other immunosuppressive drug not effective in management of insulin autoimmune hypoglycemia. A non-islet cell tumor, this is IGF-2, which is a benign or malignant solid tumor mesenchymal epithelial hematopoietic and so on. In this case, hypoglycemia, mainly post-operative hypoglycemia, hypoinsulinemia. In non-islet cell tumor, serum insulin is low, C-peptide of course is suppressed, and the growth hormone IGF-1 and IGF-binding protein 3 are also low. IGF-2 is elevated. The ratio of IGF-2 to IGF-1 is elevated. This is a ratio of 10 or more is diagnostic. And of course, administration of intravenous dextrose glucagon can be given in severe cases. And of course, total parenteral nutrition may be needed. And complete طبعا resection of the tumor is the main modality for treatment. This is another topic, which is the guidelines published by GBDS for hospital management of hypoglycemia in adults with diabetes mellitus. This is the latest edition. And this is very important because in every exam, at least 2 questions from this guideline. Just I will summarize it in some hints and repeated the paragraph. I will skip it. Of course, the risk of hypoglycemia, risk factor for hypoglycemia in the case of diabetes. Of course, if we try to tight control glycemic control, we receive a high risk of hypoglycemia, previous history of severe hypoglycemia, long duration of type 2 or duration of insulin therapy in type 2, hypertrophy at injection site, impaired awareness of hypoglycemia, severe hepatic dysfunction, impaired renal function, of course, sepsis, inadequate treatment of previous hypoglycemia, terminal illness, or cognitive dysfunction or dementia. This is medical issues to increase the risk of hypoglycemia. A lifestyle issue, increase the exercise, irregular lifestyle, alcohol, aging, early pregnancy, breastfeeding, no or inadequate blood glucose monitoring, and of course, reduced carbohydrate intake or absorption can cause increase the risk of hypoglycemia. This is very important. The concurrent use of medications with hypoglycemic agents can increase the risk of hypoglycemia, like warfarin, quinine, salicylate, fibrate, sulfonamide, MAO, non-steroidal, propansin, somatostatin, esterol. This is very important hint. Adults who are experiencing hypoglycemic symptoms but have a blood glucose level more than 4, treat with a small carbohydrate snack only. No role for intramuscular glucagon, no role for intravenous dextrose. If blood glucose is more than 4 millimole per liter, treat just with a small carbohydrate snack. This is a patient present by symptoms of hypoglycemia, but blood sugar is more than 4. Just treat with a small carbohydrate snacks. And this table is very, very important because this is summarize all the guidelines. In the first one, in a case of mild hypoglycemia, which by simple words, adults who are conscious, oriented, and able to swallow. Adults who are conscious, oriented, and able to swallow. So the management of this hypoglycemia by oral intake. Give 15 to 20 grams of a quick-acting carbohydrate like 5 to 7 dextrosol tablets or 4 to 5 glucotape. The numbers is very important because in the exam, this number may be modified. To put this option is an incorrect one. Another one by 150 to 200 milli pure fruit juice. This is the 2 options. And of course, we must test the blood glucose level after 15 minutes. And if it's still low, less than 4, repeat up to 3 times. If it's still hypoglycemic, call doctor and consider intravenous 10% glucose at 100 milli per hour or 1 milligram glucagon intramuscular. So in our case, in our scenario, if the patient is adult, conscious, oriented, and able to swallow, and give intramuscular glucagon as the first option is not correct. Intravenous dextrose is not correct as the first option. The first option is just to give 15 to 20 grams of a quick-acting carbohydrate or a fruit juice, 150 to 200 milli. This is the only two options. To repeat this step 3 times. If not corrected hypoglycemia, this is an option to consider intravenous 10% glucose or intramuscular glucagon. Please remember, it is intramuscular glucagon, not intravenous, not subcutaneous. It is intramuscular. In NICE guidelines, it is intramuscular glucagon only, not intravenous. This is very important. In another case, if the patient is conscious, of course, blood sugar is less than 4. This is a cutoff point to diagnose hypoglycemia. Patient is conscious and able to swallow, but confused, disoriented, or aggressive. The patient is confused, disoriented, or aggressive, but able to swallow. So dextrosol is not an option. If the patient capable and cooperative, treat as for mild hypoglycemia, but if the patient is confused, disoriented, but able to swallow, we can use 1.5 to 2 tubes of glucogel. Glucogel, not gluco or not dextrosol. Glucogel. Squeezed into the mouth. Welcome, Dr. Walid.
Thank you, Dr. Khalid. Thank you.
If this step is ineffective, use 1 milligram glucagon intramuscular. I repeat, intramuscular, because in I think in a previous question they mentioned 1 milligram glucagon intravenous. This is not correct in mice. Test the blood glucose level after 5 to 15 minutes, and if still less than 4, repeat above up to 3 times. If still hypoglycemic, consider intravenous 10% glucose at 100 milli per hour. The steps is very important from step to another step for management of hypoglycemia. If the patient is unconscious or fainting or very aggressive or nil by mouth, of course, the first priority is check EBC, stop intravenous insulin, contact doctor urgently. And this is the area to introduce intravenous glucose. Give intravenous glucose over 15 minutes, and this volume is very important, 75 milli, 20% glucose, or double this volume if 10% glucose. Or 1 milligram glucagon intramuscular. There are 3 options. Intravenous glucose 10% 150, or 75 20% glucose, or 1 milligram glucagon intramuscular. There are 3 options. This is in a case the patient is unconscious, fainting, or very aggressive, or nil by mouth. There are 3 options, and I think in our exam in the previous year, I think the case like this, nil by mouth, and some options like this. There are, I will repeat this very important table. If the adult who are conscious, oriented, and able to swallow, just give 15 to 20 grams of a quick-acting carbohydrate like 5 to 7 dextrosol tablet, or 4 to 5 glucotab, or 150 to 200 milli pure fruit juice. This is the only 2 options. No rule for intravenous glucose or intramuscular glucagon in this setting. Firstly, to repeat this 3 times. If failed, the next step is intravenous glucose or intramuscular glucagon. Another scenario, if the patient is conscious and able to swallow but confused, disoriented, or aggressive, there are just 1.5 or 2 tubes of glucogel. This is the only option. If ineffective, use 1 milligram glucagon intramuscular. And of course, this may be repeated 3 times. If failed to correct the hypoglycemia, we can consider intravenous dextrose 10%. And we must know that in the all guidelines, there is no 50% glucose, just 10% and 20%. This is the only 2 concentration of glucose in this guideline, because in the previous guidelines, they mentioned that there is a glucose 50%. removed from the updated guidelines published in the previous year. I will mute some. Okay. If the patient is unconscious, spitting, or very aggressive or nil by mouth, there are 3 options: intravenous glucose, 10% 150, or 20% 75 milli, or intramuscular glucagon 1 milligram. If glucose is now 4 or above, follow up treatment as described in the left. This is 1. And of course, if the patient is not improved, we can give glucose 10% glucose infusion at 100 milli per hour until no longer nothing in PM or reviewed by the doctor. And of course, after improvement of hypoglycemia, we must give 20 grams of long-acting carbohydrate, to biscuit, a slice of bread, 200 to 300 milli of milk, which is in the next meal containing carbohydrate. Give this sample may be doubled if intramuscular glucagon is used to replenish the liver. For patient with enteral feeding tube, give a 20-gram quick-acting carbohydrate via enteral tube. This is very important. After improvement of hypoglycemia, of course. This is a repeated one. Adults who are nil by mouth, because in this scenario they mentioned that if the nil by mouth, we can give dextrose 10 or 20% glucose in this one. Adults requiring enteral or parenteral feeding. Adults requiring enteral or parenteral feeding, how to manage hypoglycemia, and this is separate guidelines published by GPDS. In event of hypoglycemia, there are 6 options. 2 glucogel tube, not for use with a fine bore nasogastric tube. يبقى give one of the following via nasogastric tube. 2 glucogel tube, or 1 bottle of glucojuice or orange juice, 150 to 200 milli, or 40 juice, 110 to 140, not 40 sep, 40 sep, no 40 sep. And another important one is to restore the feed to rapidly deliver 15 to 20 gram carbohydrate. This is 1, 2, 3, 4, 5. Follow this treatment with flush or the nasogastric tube with water, or give intramuscular glucagon. So, in a case of adult requiring enteral or parenteral feeding hypoglycemia, there are 6 options. If we see 1 gram intramuscular glucagon, this is the best one. Or restart الفيد to rapidly deliver. يعني اللي مش عايز يحفظ الارقام، لو شاف intramuscular glucagon اختارها على طول، لان هي اجابه صحيحه. Any one from these 6 options is correct. 2 glucogel tube, or 1 bottle of glucojuice or orange juice by this volume, or 40 juice, or restart الفيد to rapidly deliver 15 to 20 gram carbohydrate or intramuscular glucagon. This guideline is not very important. Dr. Ahmed, yes, Dr. Ahmed. دكتور احمد فيصل اتفضل يا دكتور احمد.
ايوه يا دكتور خالد، هو اورنج جوز ده يعني حاجه تركيب عندهم ولا اورنج عموما يعني؟
نعم مره ثانيه.
مكتوب من ضمن الاوبشن من 6 اوبشن يعني الاورنج جوز.
I think يعني الاورنج جوز نفسه لو حسبته هتلقى فيه تقريبا 15 ل 20 جرام كربوهيدرات، I think هو ما يفرقش يعني. بس
تمام. لكن الحاجات الثانيه دي تركيبه يعني حاجات ثابته يعني جلوكو جوس والفورتي جوس دي زي ما يكون حاجه جاهزه هم.
حياه ثابته. هو لو اي عصير 150 ل 200، بس ما تنساش ان لو عيان كرونيك كدني ديزيز او كده ده طبعا فيه بوتاسيوم، فممكن يتحط في الحسبان وانت بتختار هذا الاختيار. يعني احنا بنبص على السيناريو كله and according to the scenario we choose the one. عشان كده اسهل واحده الانتراماسكولار جلوكاجون، لو موجوده خلاص مؤكد ان دي صحيح، يعني عشان ما تحتارش في الارقام، لان برضه في الامتحان الفعلي numbers may be different So we must memorize these numbers.
أي.
These guidelines published by the Endocrine Society since I think 10 years. It is not very important, but the same. We can review it rapidly. Of course, this is the same. This is table, the same. We mentioned the previous drugs can potentiate hypoglycemia and the cause of hypoglycemia in adults. This is very important. Negative imaging does not exclude the insulinoma. In every case of endocrinological disorders, we cannot use imaging study to diagnose endocrinological disorder. For example, primary hyperparathyroidism or acromegaly or Cushing and so on cannot be diagnosed by imaging study as a first option. So we must diagnose this disorder by lab in the first, and after that we must do imaging modality for localization. Diagnosis of insulinoma require clinical and biochemical evidence before any attempt to recognize or localize the tumor. And of course, negative imaging does not exclude the insulinoma, because the CT, for example, can detect about 80%, MRI can detect about 85% only. So about 20% of a case of insulinoma cannot be detected by our imaging modality. And in some scenarios, the surgeon do distal pancreatectomy as he hopes that insulinoma present in distal part of pancreas. And this table we mentioned the previous, and we will show it in the next cases. This is table from the guidelines and published in the Williams textbook of endocrinology. This is American Diabetes Association work group on hypoglycemic classification. This is very important just to we memorize it. Severe hypoglycemia means hypoglycemia and the patient requiring assistance of another patient. So severe hypoglycemia does not mean blood sugar is less than, for example, 35 or so on. In any case of hypoglycemia, the patient cannot recover by himself from hypoglycemia. This is a severe hypoglycemia. Documented symptomatic hypoglycemia, this is blood sugar is less than 3.9, and there is a symptoms of hypoglycemia. This is a documented symptomatic. Asymptomatic hypoglycemia, blood sugar is low, less than 3.9, but the patient is asymptomatic. A probable symptomatic hypoglycemia, there is a symptoms of hypoglycemia, but we did not record a blood glucose, so we diagnose it as a probable symptomatic hypoglycemia. Relative hypoglycemia, blood sugar is normal, more than 3.9, but the patient is manifested by symptoms of hypoglycemia. This is a relative hypoglycemia. تقريبا I finished the presentation of hypoglycemia, and if anyone want any question about hypoglycemia, because I will show some question about the hypoglycemia from a previous exam and from our El-Zohri MRCP question banks. If anyone has a question or comment or suggest anything, Dr. Sufyan, Dr. Ahmed, Dr. Iman, Dr. Khalid, Dr. Walid, Dr. Muhammad, Dr. Narmar, Dr. EK.
كان في بس سؤال عندي في الانسولينوما يا دكتور خالد.
Yes.
هل فيه ريشيو محدد للانسولين ليفل على السي بيبتايد او نو؟
طب انا رايح اوريك الدياجنوستيك كرايتيريا، لان هي محطوطه من رقمين، والارقام المهمه كالتالي. يعني على الاقل بتاعه دي جرين سبان بصراحه هي الارقام بتاعته. دي الدياجنوستيك كرايتيريا فور انسولينوما. هو حاطط كات اوف بوينتس، but even plasma insulin, the method of detection of plasma insulin is different as a cut-off points. By RIA or ECMA is different. here he did not mention specific ratio for pro-insulin to insulin or C-peptide. Just elevation, blood sugar is low, serum insulin is elevated, C-peptide is elevated, and the pro-insulin is elevated more than this number, and beta hydroxybutyrate is low and screening. And this is another criteria from Oxford Handbook. They mentioned that elevated C-peptide and pro-insulin, not the ratio. And also, this is from Greenspan, this is one, and this is from the guidelines. If we see this, the insulinoma category, they mentioned that the serum insulin is just more than 3, and C-peptide is more than 0.2, and the pro-insulin is more than 5, and beta hydroxy is less than 2.7, and so on. So I think the ratio is not a diagnostic criteria, just numbers. And of course, in this scenario, there are 3 options as a differential diagnosis in this category: insulinoma versus post-gastric bypass versus a non-insulinoma pancreatigenous hypoglycemia. And this, I think, by CT or MRI or another model can be differentiated. انت لو تفتكر ارقام كريشيو دكتور سفيان او في مكان معين ذاكرها، بصراحه انا ما شفتش الريشيو كارقام يعني. انا اوريك دي
وبس في ماي كوليج حكى لي على الريشيو، بس انا ما شفتهاش بصراحه، ما I didn't see it before.
Okay. Just to review some question to memorize, but in this question we must interact. عايزين الناس تشترك في الأسئلة، هي أسئلة بسيطة مبدئية. This is the first question from practical days. I would mention that this program, if anyone is not download this program, just download it from the website. I share the link and I can send the password or for the program. This is the first one. If anyone want to read, Dr. Sufyan, مشتاقين لأصواتك.
مش مشكلة. Hypoglycemia is a common side effect of insulin and sulfonylurea. The current use of certain medications with hypoglycemic agents, sulfonylurea or insulin, can further increase the risk of hypoglycemia. All of the following can increase the risk of hypoglycemia when used with anti-hypoglycemic agents except quinine sulfate, aspirin, warfarin, fibrate, nicotinic acid derivative.
5.
5 nicotinic acid derivatives.
Yes, of course, nicotinic acid derivatives is one of the drugs that can cause hyperglycemia. And this is from the guidelines. This is a drug can cause hypoglycemia. Warfarin, as we mentioned, that warfarin, quinine, aspirin, and fibrate. This is from the guideline. Okay. Another question.
A 44-year-old woman was admitted for further investigations of her hypoglycemic episode. Her 24-hour fasting blood results shown below. Blood sugar 2.2, insulin 155, C-peptide 10.5, sulfonylurea screen negative.
So in this scenario, blood glucose is low, insulin is elevated, C-peptide is low, sulfonylurea is negative. What is the next best step to establish the likely underlying diagnosis? من غير ما يشوف الاختيارات يعني. In some question like this, try to solve
imaging
before imaging for what? What is the diagnosis here?
Exogenous insulin.
Yes. Serum insulin is elevated, the C-peptide is low, and sulfonylurea screen is negative. So the diagnosis here is insulin abuse. Yes, insulin abuse. So imaging and next and so on is not correct one. So what is the next best step to establish the likely underlying diagnosis?
Inquire about likely use of exogenous injection.
Yes, 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 because we diagnose it in this scenario. This is one, which is insulin abuse, exogenous insulin abuse. This is one. insulin is elevated, the C-peptide is suppressed, and symptoms of hypoglycemia and the blood sugar is low, so it is exogenous insulin abuse. The best one is inquire about likely use of exogenous injection. Of course,
Yes,
this is another one.
18-year-old woman was referred by her GP for further investigations of body turn, during which she developed palpitations, sweating, tremor, hunger, anxiety, and paresthesia. All of these symptoms were relieved immediately by a sugary drink. She was otherwise well and was not taking any regular medication. There was a family history of type 1 diabetes. A spontaneous hypoglycemic episode had not been captured, and she was admitted to the diabetes endocrine ward for 72-hour fast. Her renal function were normal. After 12-hour fast, she experienced her typical symptoms. Urinary analysis shows no urinary ketone. Investigations after 12-hour fast, fasting blood glucose 2, plasma insulin 56,
insulinoma, CT.
serum C-peptide 514.
Yes, as Dr. Ahmed Faisal said, the fasting blood sugar is low, serum insulin is elevated, the C-peptide is elevated. There are 7 or 6 differential diagnoses of this category. For example, insulinoma, non-insulinoma Pancreas hypoglycemia, sulfonylurea abuse, a lot of differential diagnoses. So what is the most appropriate next step in the management? what is الأوقع انسولينوما ولا sulfonylurea abuse؟
insulinoma.
We have to get urinary screen for sulfonylurea.
Yes, insulinoma prevalence of insulinoma just 1 or 2 cases per 1 million population. So it is very, very, very rare. In this patient, and there is a family history of diabetes, the abuse of a drug is the first one to consider. So we must, in every criteria for diagnosis of insulinoma, for example, insulinoma, the last one, which one? Negative screen for sulfonylurea. We cannot proceed for diagnosis of insulinoma and require MRI abdomen and endoscopic ultrasonography and operation and give the patient diazoxide or and so on. Easily. The simple way is to exclude the sulfonylurea. This is the simple way. Request a urinary sulfonylurea screen on a sample obtained during the fast.
Yeah.
Okay, just I have a phone. You can go, Dr. Sofiane.
30-year-old man was reviewed in the diabetes clinic. He had type 1 diabetes duration. Treated with subcutaneous insulin in a basal bolus regimen. Short-acting insulin 3 times a day, long-acting insulin once daily. Investigation HbA1c 52. At what arterialized venous sample glucose threshold would patient typically expect to develop neuroglycopenic symptoms? 2.2, 2.5. 2.5. Any other suggestion?
Sorry for interruption, Dr. Sofiane. Go on.
No, that's fine. We are talking about the level of hypoglycemia with neuroglycopenic symptoms. I said 2.5.
Which level?
Less than 2.5.
Yes, which one?
I mean, this is okay.
VB
2.3 to 2.6, I think.
This one?
B
or C?
maybe C.
Type. I think we mentioned that neuroglycopenic at 2.8.
Okay.
Okay, 2.8. This is very important. 2.8. So 2.8 in this ratio. 2.7 to 3.
Again دكتور خالد السلايد اللي قبل اللي كانت فيها
ايوه This is first slide in our presentation. The adrenergic symptoms at 3.3, neuroglycopenic at 2.8. Of course, glucagon and another counter-regulatory hormone is the first to be occurred at 3.7 in a case of hypoglycemia less than 3.9. Stimulation of glucagon, epinephrine, growth hormone. After that, autonomic symptoms at 3.3, and cognitive dysfunction or neuroglycopenic symptoms at 2.8. This is a number we must memorize this number as it is. This is from the guidelines. A question from the guideline.
72-year-old man with dense residual hemopharesis and unsafe to swallow was fed via percutaneous gastrectomy for 20 hours each day. He resided in a nursing home and had type 2 diabetes that had been well controlled on metformin. His glucose concentration were uncontrolled on metformin powder at a maximum dose. While not being fed, his blood glucose was measured. Investigation, capillary blood glucose 3.1. What is the most appropriate management? So he's unsafe to swallow. 40 sep, I think it's not appropriate because it's 40 juice.
Yes.
Glucogel, not necessarily, because we can't use glucogel because he's unsafe to swallow, and we can't use it in the gastrectomy tube. Glucogel, buccally, unsafe to swallow again. Glucose 20%, that's not correct because it should be 20%, 75 ml.
Yes.
To 100. And the right options is E, restart feed.
Yes. As we mentioned the previous, there are 6 options. A glucogel tube, not for use with the fine. Here, there is no glucogel to down gastrostomy tube. And 40 sip, of course, not 40 sip. He mentioned that not 40 sip. It is 40 juice by this number. And another one, restart feed to rapidly deliver carbohydrate or intramuscular glucagon. This is the options. So restart feed to deliver carbohydrate 20 gram rapidly is the best one.
42-year-old woman underwent Roux-en-Y gastric bypass 6 years ago, was admitted overnight following a third episode of collapse in a course of a year and is followed up in the endocrine clinic. She says that symptoms during an attack are always the same, with the palpitation, sweating, and anxiety, and that if she has an access to carbohydrate, an episode has been reported. Mixed meal test performed as an outpatient showed evidence of hypoglycemia accompanied with hyperinsulinoma 40 to 60 minutes after the test milkshake was administered. Which of the following is the most likely diagnosis?
انا لاحظت الدكتوره ايمان كانت كاتبه الصوت مش واضح. انا الصوت مش واضح يا دكتوره ايمان. احنا جربنا نخلص.
لا ده من بدري وبعد كده كتبت الصوت واضح.
لا طب يعني ماشي اوكي. اصل لسه طب which of the following is the most likely diagnosis? So it is a post gastric bypass hyperinsulinemia after 45 to 60 minutes after the test milkshake was administered. Which of the following is the most likely diagnosis?
Early dumping.
Gastric dumping syndrome, that's not correct because it's usually after 15 minutes.
Yes.
Insulinoma, no. Nocidioblastosis, most likely. Short bowel syndrome, no. Sulfonylurea abuse, unlikely. I'll go for nocidioblastosis.
Yes. After post-gastric bypass, hypoglycemia mostly caused by nocidioblastosis. And of course, in this scenario, serum blood sugar is low, serum insulin is elevated, and C-peptide is elevated, and mostly occurred after 45 minutes or 60 minutes. It is postprandial hypoglycemia.
54-year-old woman with a history of type 2 diabetes visits the emergency department because of profound hypoglycemia while shopping at the supermarket. According to her husband, she takes glimepiride for the management of her diabetes and had recently been prescribed some medicine for a discharge down below. Which of the following medication may have precipitated an interaction leading to hypoglycemia?
يبقى drug interaction which can cause hypoglycemia.
I'm not sure. Fluconazole because of the discharge down below. Fluconazole.
Which one?
Fluconazole.
Fluconazole. Okay. Trimethoprim, of course not, because we mentioned cotrimexazole. Paracetamol is not. It is aspirin, which can
آخر سطر في السؤال كان إيه الميديكيشن discharge down
This is
discharge
one.
down below.
Yeah, so she had the symptoms of discharge down below in the private area. He means.
يعني
What?
So he has a vaginal discharge.
hello.
A drug interaction with glimepiride, which can cause profound hypoglycemia. So it is a fluconazole. And this is a case of DKA treated by, according to the protocol. On examination, hair pulse just 118 beats per minute, and the blood pressure is normal. Serum sodium is okay, potassium is okay, creat is okay, blood sugar is 7.3, and serum bicarb is 15 millimole. What is the most appropriate next step in the management of a case of not resolved DKA and the blood sugar is 7.3? Increases subcutaneous basal insulin at bedtime, increases subcutaneous bolus insulin with meal, start fixed rate insulin, intravenous insulin infusion, start glucose 5% with fixed rate intravenous insulin, or start glucose 10% with fixed rate intravenous insulin.
10%.
Yes, of course, start with 10% with fixed rate. This is a repeated question from the exam. We just a few questions and the presentation is finished. Dr. Sufyan or Dr. Walid?
Yeah. 72-year-old man was admitted with the left hemiparesis. He had type 2 diabetes. Nasogastric tube was inserted and intrafeeding was started over 18 hours with premixed insulin giving at the start and midpoint of the feed. The nasogastric tube became blocked 2 hours into the feed and the feed was stopped. 3 hours later, he became unarousable. Investigation CBG 2.1. What's the most appropriate acute management? Buccal administrations of 1 tube of glucogel, probably not. Intramuscular administrations of glucagon could be. Administration of 50 ml of 50%, no. Nasogastric administration of 100 ml of 40 steps, no. Nasogastric administration of 100 ml of glucoside.
Glucoside اتلغت from the previous in the latest guidelines. Glucoside is removed as a management of hypoglycemia. In the previous guidelines, glucoside is present an option, but in the latest one, there is no glucoside.
Yes.
B.
Yes, once we see intramuscular administration of 1 milligram glucagon in a case of enteral feeding or nasogastric tube or left hemiparesis, we must choose intramuscular glucagon. This is the guidelines. There are 6 options. One of them is intramuscular glucagon. This is a very important question from ESAB.
You are asked to evaluate a 24-year-old man who collapsed during an outdoor music festival 3 days earlier. Since his arrival at the hospital, he has developed an intractable hypoglycemia, which has required a continuous 10% dextrose infusion. He has no notable medical history. He takes no regular prescribed medication, but he did consume amphetamine while at the music festival. His mother has type 2 diabetes treated with glibenclamide and metformin. On physical examination, he is alert and oriented and centrally obese with some purple striae over his abdominal wall and inner thighs. BMI is 32.1 kg per cubic meter. His blood pressure is 148/99. Pulse rate is 90. Sodium is normal, potassium is normal, urea is 14, creatinine 0.9, glucose 53, insulin is 0.2, which is low, C-peptide 0.1, which is low, ketones is low as well, TSH is normal, 3T4 is normal, early morning cortisol is okay.
So in this case, blood sugar is low, serum insulin is low, C-peptide is low, and beta hydroxybutyrate is low. So what is the differential diagnosis here? Hypoglycemia.
IGF-2.
Yes. And this is the CT abdomen and shows this is adrenal tumor. Which of the following tests is most likely to reveal the cause of this patient hypoglycemia?
Serum IGF-2 to
Yes.
IGF-1.
Yes, this is the best one. Of course, this is one, the IGF. Serum insulin is low, C-peptide is low, and of course, proinsulin and beta hydroxybutyrate is low. This is the IGF one. IGF. Okay. This is some question from a previous 4 years examination, and we can some of the questions just written like this: post bypass hypoglycemia 2 to 3 hours after the food, already changed his diet to smaller meal, still symptomatic. What to do? Acarbose or octreotide? Of course, the best one is acarbose in a post gastric bypass after a diet modification. Diazoxide and octreotide is an option, but after acarbose. This is another question about type 1 diabetes lady post CVE on enteral feeding on pre-mixed insulin with second dose halfway through the feed team. حصل aspiration, feed been off for 2.5 hours, given dextrose during this time. What to do next? This is an example of a question in this year. This is not my exam, so the question is just recall from another one. Question about unwell diabetic on enteral feeding hypoglycemia. What treatment to give patient is conscious? And of course, this is the enteral feeding and the patient is conscious. We can give one from these 6 options according to the options available in the exam. Elderly hypoglycemic post-operative and conscious, how to manage? Elderly hypoglycemic post-operative conscious, how to manage? This is the guidelines for management of adults with diabetes undergoing surgery. If the patient is hypoglycemic in a perioperative period, if blood sugar is from 4 to 6, we can give 50 milli of 20% glucose. If blood glucose is less than 4, we can give 75 to 100 milli of 20% glucose. Malnourished hypoglycemic patient not responding to glucagon injection, low liver glycogen. What is the option? Of course, intravenous glucose. If anyone want to answer this question, hypoglycemia and unconscious, what is the options available?
IM glucagon or IV 150 10%.
Yes, there is 3 options: intravenous glucose, 10%, 150, or 20%, 75, or 1 milligram glucagon intramuscular. This is the options for management of hypoglycemia. Hypoglycemia management in outpatient can swallow. What is the options?
140 juice or 200 ml of orange juice or 4 tablets of glucose tablets.
Yeah. The mainly there are 2 options. All of them is 15 to 20 gram of a quick acting carbohydrate like 5 to 7 dextrosol tablets or 4 to 5 glucotab or 150 to 200 milli pure fruit juice. Hypoglycemia management in a tube feeding unresponsive. Of course, there are 6 options as we mentioned previously. This is a question from our exam in 2018. A type 2 diabetes in metformin, 500 twice daily with gliclazide 80 milligram. Hemoglobin A1C is 7.5, GFR is 48, complaining from several attacks of hypoglycemia. How to manage? Stop gliclazide and reassess, or stop gliclazide and increase metformin, or stop gliclazide and add linagliptin, or stop gliclazide and add pioglitazone. What is the best one, Dr. Sufyan or Dr. Ahmed?
بالنسبة للجي اف ار عشان 48 ليناجليبتين هو ال most preferred according للجي اف ار. ميتفورمين ما اعتقدش ان هنزوده يعني مع الجي اف ار ده
طبعا.
لازم هنزود حاجة طبيعي يعني مش هينفع نعمل هنوقف الجليكلازايد دي بس. البايوجليتازون برضو مع جي اف ار 48
هو سيف مع ال 48 بس المشكله الاديمه والووتر ريتيشن. اوف كورس الليناجليبتين از ذا بيست وان. Of course, why to stop gliclazide and hemoglobin A1C is 7.5 because hypoglycemia. The most offending drugs that cause hypoglycemia in this scenario is gliclazide, so we must stop gliclazide. Some options, some doctors.
طب حاجة كدكتور كان مدي كلو ان يعني ان العيان مثلا كارديوفاسكولار او يعني ان هو في ريسك السلطان ووتر ريتنشن يعني عشان ما اختارش.
لا ما انت بالنسبه لك لو عيان كرونيك كدني ديزيز اند 2 اوبشنز ليناجليبتين اور بايوجليتازون which is the best
طبعا طبعا.
في بعض الدكاتره اقترحوا طب ليه ما ستوب كليكلازايد اند ري اسيس بس.
ما اللي هي A1C 7.5.
So yes, I am with you. Hemoglobin A1C is not ولو بطلت كليكلازايد توقع ان رايح يعلى ل 8 ونص كده فلازم اضيف دواء تاني طبعا. Stop gliclazide and linagliptin is the best one.
17-year-old with type 1 diabetes was admitted with DKA precipitated by a recent viral illness.
In our exam, this is a question from our exam in this year.
Investigation RBC 15, ABG, breathing air, pH 7.07, 8 or hydrogen ion 85. Investigation after initial treatment with the fluid insulin and potassium 7 hours after admission. Are random blood sugars 4, serum bicarbonate 10. At this stage, he was given infusion of insulin 1 unit per hour and glucose 5%, 100 ml per hour. what's the most appropriate next step of management. Continue current regimen, but encourage oral carbohydrate intake. Continue insulin infusion and change glucose to a higher concentration. Give intravenous insulin, intravenous sodium bicarb. Stop insulin infusion if glucose fall any further, then repeat plasma glucose in 15 minutes.
Which one, Dr. Sufyan?
Can you go back, Dr. Khalid?
This is just blood sugar is 15. Investigation after initial fluid. The potassium is elevated. Random blood sugar is low, 4. Serum bicarb is low, so it is still diabetic ketoacidosis.
So you still acidotic, so we need to continue the insulin infusion, but we need to increase the concentrations of the intravenous glucose to 10%.
Yes, I am with you. Continue insulin infusion and change glucose to a higher concentration. This is another question. 26-year-old physiologist was seen in the diabetes outpatient clinic. She or he had type 1 diabetes mellitus of 9 months duration, treated with subcutaneous insulin. She asked what symptoms of hypoglycemia she might experience. In what order a response to hypoglycemia most likely to occur as blood glucose fall? Which order?
C.
C, yes, of course, the counter-regulatory hormone is the first one. After it is autonomic, after it immunoglycopenia. Patient present with symptoms of hypoglycemia. Random blood sugar is low. Serum insulin is low. C-peptide is low, and negative serum sulfonylurea screening. What is the next step? A lot of options, but it is autoimmune antibody or IGF. احنا قلنا الانسولين اوتو انتي بودي السيرم انسولين از
elevated.
This is the insulin auto antibody. Insulin autoimmune. السيرم انسولين is high, not low. In IGF زي الحاله بتاعت الايساب السيرم انسولين is low والسي بيبتايد is low and so on. So order السي abdomen and pelvis. ده السؤال لو تفتكروا دكتور سفيان بالتفاصيل بتاعته، يعني انا مش فاكر التفاصيل كلها وجاوبته غلط يعني على ما اعتقد ان انا اخترت بصراحه الانسولين اوتو انتي بودي، بس الواحد ما كانش في باله، يعني انت عارف الواحد ما جراش الموضوع بالتفصيل زي المحاضره كده، او ركز ان في حاجه اسمها انسولين اوتو انتي بودي والاي جي اف والتفصيله دي بصراحه. اما هو الكوريكت انسر از سي تي ابدومين اند بلفيس بيكوز ات از اي جي اف.
هذا فاكره كويس.
طبعا لان كان من الاسئله الجديده والاسئله الصعبه بالنسبه لنا بصراحه. This is the summary of my presentation. It's by 2 slides. This is a very important slide to differentiate between the different types of hypoglycemia. And another very important slide, this one. This is
معلش يا دكتور خالد، السلايد الأولى دي where is the source? Sorry, because
this is from Greenspan, not Greenspan, Williams, the latest edition.
William.
And the original table from the guidelines published by Endocrine Society for Management of Hypoglycemic Disorder in Adults. This is I will upload these 2 sources. The main one I mentioned previously. This is one I will show it. This is from the guideline.
Okay.
This is the guidelines. This is the original one. This is the same table. This is from the guidelines published by Endocrine Society. I will show it. This is one, endocrine adult hypoglycemia. This is a guideline published by Endocrine. This is table. This is one. And also this table is in Williams. This is the table from Williams, the same table. And here the colors and so on is very attractive. This is from Williams textbook.
Thank you, Dr.
The
Khalid.
next very important table is this one. This is the summary for this presentation, and in every exam at least 3 to 4 questions from these 2 slides, this one and this one. So I hope everyone to print it and rememorize it a lot of times. بس دي ختام المحاضره. لو شايفين تعليقات او كده او حاجات ممكن نستفيد بها المرات الجايه تحت امركم.
يا باشا جزاك الله خيرا، الواحد مش عارف يقول لك ايه بس.
ان شاء الله انا رايح اعمل ابلود لدي، بس الفتره الجايه انا على فكره انا قدمت في بوست جراديويت دبلومه بتاعت جامعه ويلز. المفروض هنبدا من الشهر الجاي بتشيتري مديول، فعشان كده انا تعمدت اني ابدا يعني الحياه بتاعتنا والانتر اكتيف سيشن زي البوست جراديويت دبلومه. فاول موضوع هنبدا فيه في البوست جراديويت دبلومه هو البيتيوتري موديول. انا حطيت ده التفصيل بتاعه تقريبا على شهر ونص تقريبا نخلص بيتيوتري. I am with you. In the first week already I finished from pituitary introduction and pituitary test and of course MRI pituitary. الدكتور ابراهيم العالي هو اللي راح يتولى قصه الايميجينج. الاسبوع اللي بعده هنتكلم عن hypopituitarism and growth hormone deficiency and the guidelines published by Endocrine Society about the hormonal replacement في hypopituitarism and the adult growth hormone deficiency. الاسبوع اللي بعده prolactinoma and acromegaly, and we have 2 very important guidelines, hyperprolactinemia and acromegaly published by Endocrine Society. There are another guidelines published by ACE guidelines in 2009 about the acromegaly, but it is outdated and not very important, so I just put the Endocrine Society guideline. And the Cushing is very important topic, and at least 2 to 3 questions in the exam, and 2 guidelines published by Endocrine Society about the diagnosis and the management. And in another week, non-functioning tumor in incidentelloma with surgery or radiotherapy, and we gave a hint about the guidelines pituitary incidentelloma and management of aggressive pituitary tumor. And in the last week, the diabetes insipidus with hyponatremia and SCE from the Oxford Handbook, and the 2 guidelines published by European Society of Endocrinology management of treatment of hyponatremia, and another one for severe symptomatic hyponatremia, how to emergency management. And in the last week, just revision to all pituitary topics. So I hope some of you prepare some topics from the guidelines or another topic, and I can help him in preparing any topic. I upload this table in our WhatsApp and Telegram group to start with in the next week inshallah. And I already جهزت the pituitary introduction and pituitary test like the same like this. والhypopituitarism also I started by hypopituitarism ان شاء الله. ده الجمعه الجايه، يعني احنا هنظبط امورنا كل جمعه رايحين نتكلم على توبيك بهذه الطريقه. البيتيوتري فانكشن تيست، الدايناميك تيست، البروتوكولز بتاعها، يعني انا ذكرتها في المحاضره بتاعت الاسبوع الجاي ان شاء الله. وجهزت الهايبوبيتيوتريزم، فان شاء الله نتقبل الجمعه الجايه. لو في حد عايز يشترك معانا برضو يحضر حاجه ويجهز حاجه، يا ريت طبعا نتشارك سويا. ونخلي في نهايه الجلسات يعني ايه نبدا ندخل على الاسئله بتاعت الزهري بانك، بحيث نبدا نحل بعض الاسئله الخاصه بالبيتيوتري، لان اخر اسبوع يبقى رايحين نبدا نحل اسئله. بس اي حد ناوي يدخل الامتحان الفتره الجايه يبدا يجهز نفسه ويحل اسئله من البنك. يعني احنا شغالين بيتيوتري، المره الجايه هنشتغل بيتيوتري، يعني نبدا نذاكر بيتيوتري بدا من النهارده او من بكره، بحيث ان في 600 سؤال بيتيوتري كل واحد يحاول على الاقل في خلال الشهر ده يحل له كل يوم مثلا 10 اسئله بتيوتر ويذاكر ويقرا فيهم، هتلقوا القصه سهله بمشيئه الله. Sorry for English language, I think all of us are Arabic. EK, who is EK?
الدكتور انا دكتوره ايمان، بس انا دخلت بالموبايل وباللابتوب علشان كان يعني كان عندي الصوت مش واضح، حاولت ادخل من هنا وادخل من هنا ففتحت
يا اهلا وسهلا يا دكتوره ايمان. لا انا بس
مثلاً زي
حبيت
ما
اطمن ان عشان انا اتكلمت شويه عربي في الاخر، فعشان كده ان ما معناش حد بره يعني.
ممكن تقفلي اللي هو الصوت من فوق وافتحيه تاني، ممكن تلاقي الصوت اوضح، لان حصلت معايا. فممكن تعملي الاون والاوف تاني، هتلاقي الصوت اوضح، يعني لو انت بتعملي من الموبايل والصوت مش واضح.
لا انا دلوقتي مش، انا صوتي واضح، انا سامعاكم كويس دلوقتي.
وصوتك واضح جدا يا دكتور. لو في اي اقتراحات حضراتكم تقترحوها للمرات الجايه او الفترات الجايه تحت امركم فيها، يعني ممكن نجهز لها.
هو احنا يا دكتور لو احنا بدأنا خدنا زي ما حضرتك عملت كده، الأسئلة بتفتح علينا حاجات كتير، يعني الأسئلة بتسهل لنا ان احنا لما نقرا التوبيك بيكون افضل يعني.
بص للامانه انا قصه الاسئله، احنا الفتره اللي فاتت والسنه اللي فاتت الشغل اللي اشتغلناه ما كناش بنحل الا اسئله، بس في الامتحان الفعلي اكتشفنا ان الاسئله مش مغطيه كل حاجه. يعني في جزء كبير من الامتحان تقريبا 60% بعيد عن الاسئله اللي كنا بنحلها، مصدرها الاساسي هو اوكسفورد هاند بوك والمعلومات اللي بنحاول نجمعها واحنا بنبص في الكتاب. انا اوريدي والجايد لاينز طبعا. يعني انا حاليا انا بعمل حاجه بسيطه دلوقتي بصراحه شغال فيها، وانا شغال ان كل اللي بشتغل فيه في كتاب اوكسفورد بعمله هايلايت. يعني رايح اوريكم كمثال زي كده، انا كتاب اوكسفورد انا ده النسخه اللي معايا على الكمبيوتر، فانا بشتغل بعمل هايلايت للحاجات المهمه، الحاجات الفيري امبورتنت، بحيث برضو انا بعد ما اخلص الجزئيه، يعني الجزئيه دي ممكن اعمل له ابلود بحيث اللي عايز يشتغل من النسخه دي او يستفيد من النسخه دي. بس طبعا ما فيش حاجه هايلايتد الا الجزء اللي انا اللي بحضره الفترات دي، لان الكلام ده انا ما بداتش اشتغله الا اليومين اللي فاتوا، يعني مش من السنه اللي فاتت. والقصه دي الدكتور محمود عزت هو اللي اقترح القصه دي بصراحه، يعني هو اللي سالني السؤال ده، طب عندك النسخه هايلايتد؟ قلت له لا للاسف، وبدات اشتغل عليها على هذا الاساس. فده مهم كتير، خاصه ان الوقت دلوقتي ما ينفعش نبدا اسئله من النهارده لان لسه على فتره طويله كتير. احنا دلوقتي في شهر 9، احنا الامتحان في 10/6. الاسئله اللي عايز يبدا اسئله بس نتكلم من شهر 2، يعني من شهر 2 لشهر 6 ما فيش الا اسئله، ما فيش حاجه ثانيه. ما ينفعش نشرح كده مواضيع ونتكلم في مواضيع الا توبكس معينه. اما من النهارده لحد شهر 2 الافضل هي طريقه نمسك الكتاب جزء الحياه المهمه بتاعته بهذه الطريقه.
نبدا باوكسفورد مثلا زي ما حضرتك قلت الاول، وبعد كده ندخل. حضرتك كنت حاطط حاجتين، قلت في حاجتين النهارده، كتاب ويليام، وقلت كمان في حاجه ثانيه تقريبا من الجايد.
ما انا حطيت اوريدي الجايد لاينز، انا حطيت الجايد لاينز بتاعت النهارده. انا اتكلمت بالضبط على التفاصيل التاليه. الجزئيه بتاعت اوكسفورد اتكلمت عن الجايد لاينز بتاعت الجي بي دي اس دي بالتفاصيل بتاعتها، اللي هو التيبل الثاني المهم بتاعها. وحطيت طبعا الجايد لاينز بتاعت الاندوكراين سوسايتي اللي هي الجايد لاينز، يعني مش مهمه كتير بس جزئيه منها صغيره. واتكلمت عن البيبر دي بتاعت مش الكتاب ده، البيبر دي بتاعت اليوروبيان الاي جي اي، الباثوجينيسيس اند مانجمنت اوف هايبوغلايسيميا شويه. وحلينا الاسئله اللي اتكررت السنوات اللي فاتت ال4 سنين وبعض الاسئله من بنك الاسئله. حطيت كام تيبل من كتاب جزئيه من جرين سبان، لان برضو جرين سبان من الكتب المحترم بس ضخم، هو مجلدين كبار يعتبر، يعني هو السورس رقم 2 للي عايز يقرا، بس الاهم اوكسفورد هاند بوك، هو ده اهم كتاب. يعني اللي ما عندوش وقت ما يبصش الا في اوكسفورد هاند بوك الكتاب ده. اللي عنده وقت خلاص يبدا جرين سبان من الكتب الرائعه طبعا، بس طبعا هو كتاب ضخم، يعني هو تقريبا 1000 صفحه لو بصيتوا عليه مثلا بهذه الصوره. يعني انا حاطط سلايدات وحاطط حاجات كتير منه في كل المحاضرات، لان بصراحه هو من المصادر الممتعه في القراءه بتاعته عموما. بس صعب اقول ان حد يذاكر فيه عشان يدخل الامتحان بكره. لو وقت زنقه لا ما ينفعش جرين سبان يكون قدامك اصلا، ما تحطش الا اوكسفورد. اما احنا بالنسبه لنا عشان في وقت كبير فممكن نحط جرين سبان قدامنا، نحط اوكسفورد هاند بوك على الاقل ال3-4 شهور الجايين، وبعد كده هنرمي جرين سبان خالص، وكل اعتمادنا الاساسي على اوكسفورد هاند بوك والجايد لاينز. الجايد لاينز مهمه كتير، في كل مره هنحاول نحط جايد لاينز تابعا للموضوع بتاعها. فلو في اي اقتراحات للمرات الجايه انا تحت امركم، بس انا كده او كده لازم نبدا بتيوتري. يعني الموديول بتاع بتيوتري، وبعدين ثايرويد، وبعد الثايرويد ادرينال، وبعديها الباراثايرويد، وبعدين الجونيتس، وبعد كده كانسرز او اندوكراين ريليتد كانسر. فهتبقى بهذا الترتيب ان شاء الله الفترات اللي جايه. بس يعني يا ريت اتمنى ان كل المجموعه تبقى انتر اكتف، كل المجموعه تبدا من النهارده تذاكر بتيوتري.
اوكي.
وتحل اسئله على الاقل لو من كتاب اوكسفورد هاند بوك، نقرا الجزء بتاع البيتيوتري صفحه صفحه. وفي كان المحاضره بتاعت الدكتور اتول، انا ما اعرفش موجوده عندكم ولا لا، احنا حاطينها على الميديا فاير. الدكتور اتول كان عامل محاضره عن البيتيوتري، الدكتوره نكيره كانت عامله لها ابلود، موجوده على الميديا فاير. ممكن اشير اللينك بحيث ممكن ننزل
يا
المحاضره
ريت
بتاعت.
حضرتك لو حضرتك تشيرها تاني معلش.
هو اللينك انت لو عندك اللينك بتاع الميديا فاير هو اوريدي موجود على اللينك بتاع الميديا فاير، بس انا شير اللينك عموما بحيث
تمام.
محاضره بسيطه ساعه ونص تقريبا ساعتين، يعني جزئيه البيتيوتري ظريف. وفي المحاضره بتاعت الدكتور ابراهيم العلي السنه اللي فاتت عمل لنا محاضره عن الام ار اي بيتيوتري. ان شاء الله الاسبوع الجاي اظبط مع الدكتور ابراهيم البيتيوتري ام ار اي مع الانترودكشن اللي عاملها انا عن البيتيوتري فانكشن تيست والانترودكشن بتاعت البيتيوتري. بس انا عايز اشوف الوقت ده مناسب ولا مبدره شويه ولا امتى؟ هو يوم الجمعه.
دكتور يا ريت يكون بدري شويه. هو انا بالنسبه لي دلوقتي الساعه عندي الساعه 2.
ليه من فين حضرتك يا دكتوره ايمان؟
الامارات، فانا فرق ساعتين بالنسبه لي.
انا بصراحه الدكتوره ياسمين هي اللي اقترحت ميعاد الساعه 10 والتزمت عشان خاطرها، بس هي ما حضرتش النهارده، فعشان كده مش رايح، يعني رايح اغير الميعاد على حسب اللي تحبوه انتوا. يعني اللي يهمني الناس اللي بتحضر. الدكتوره ياسمين من الناس الكويسه كتير وكان نفسي تكون معانا، بس هي ما حضرتش في الغالب عشان ظروفها. فهنشوف الميعاد اللي يناسبكم. لو تحبوا بعد صلاه الجمعه بشويه مثلا على الساعه 1 2 جي ام تي مثلا، براحتكم يعني، انتوا اختاروا الميعاد. انا كده او كده فاضل الجمعه فما فيش مشكله بالنسبه لي، بس كده او كده
بعد صلاه العشاء يعني، لو بعد صلاه العشاء مثلا 8 9 في الحدود
طيب.
دي.
طب ايه رايك
يعني
لو
مقصرها ساعه او ساعتين، لان هيبقى مثلا في صلاه في النص، فعشان ما يحصلش انتربشن برضو بعد صلاه الجمعه الناس ممكن لو بتتغدى مش عارف ايه مشوار.
طب لو تحبوا بعد صلاه العشاء اوكي، بعد صلاه العشاء بتوقيت مصر، ففي الغالب يعني بنتكلم على
هيبقى عندي 10 كويس.
تقريبا 6 جي ام تي تقريبا.
تمام.
طب خلاص يبقى نظبطها كده من المرات الجايه الاسبوع الجاي، ونشوف برضو الدكتور ابراهيم مواعيده ايه والدكتور سفيان والمجموعه دي. انتوا الساعه كام عندكم دكتور سفيان؟ طيب انا شكل الناس نامت، فتصبحوا على خير ونشوفكم على خير الساعه 12 منتصف الليل بتوقيت مصر.
جزاك الله خير يا دكتور خالد، جزاك الله خير يا
جزاك الله خير يا دكتور خالد.
مع السلامه.
شكرا.
سلام.
شكرا.
السلام عليكم.
مع السلامه. الله يسلمك.